Welcome back, friends. Welcome back to Saturday Club meeting. And today we have a very special speaker, Dr. Kiran Shah. Kiran Shah has been part of the Saturday Club meeting for a very long time. In past, we had several talks by him. Somehow in the pandemic, he was lost, and we have regained him today. And to introduce him is a pleasure because he's a very senior consultant physician of Baroda. He has more than 3 decades of experience of clinical practice. He is director of Spandan Multi-Speciality Hospital, and he has several presentations at national and international conferences. So welcome back, Dr. Kiran Shah. And Dr. Kiran Bhai will be talking about synopsis of Epicon 2022, the conference which he had attended at Jaipur. So over to you, Kiran Bhai. You will speak for about 40-45 minutes, and then we'll have 10 minutes of question answer session.
Okay. Good morning, and thank you, Satish Bhai, for your kind words of introduction. Yes, I was actually the member of this Saturday Club, and I was presenting it in past. But somehow, because of the pandemic in Corona, I had not touched this Saturday Club. But yes, again, I will now be in touch with you people. It's my pleasure to see all seniors. So I was very eager to see all the faces also. So actually, I requested Satish Bhai and Kiran Dalal to see all the faces. Anyway, so good morning to everyone. So respected teachers, seniors, and colleagues. Today, I am going to present Epicon update. Okay.
Yeah.
Okay.
Yes, this is visible and you are audible also.
Okay. So today I'm going to present an Epicon updates. Actually, it's a very big conference and it is not possible to cover each and every aspect that you all know. This was the Epicon, that is Association of Physicians of India conference. It was held in Jaipur in 2022 from 14th to 17th April 2022. Actually, this conference was 2020, but because of the Corona pandemic, it was postponed for 2 years, that is 221, but it was not possible. And again, it was possible only in 2022. This is the Epicon logo. It was held in JECC, that is Jaipur Exhibition and Convention Center, that you all know. It is the JECC is the largest pillarless exhibition, conventions, entertainment facility of its kind in South Asia. And you already know that Jaipur is the pink city, the World Heritage City. Moreover, JECC has in place a high-tech facilities, which includes halls equipped with avant-garde sound acoustic that solves noise and sound and related issues and gives optimum clarity. Yes, I had experienced that, and it was really a very nice convention center, no doubt. It has located nearly in the 10-kilometer area from the Jaipur airport, and weather was also nice. But in this time, the outside temperature was, obviously, it was 43, but it was very pleasant atmosphere in the convention center itself. This convention center is spread over the 42 acres area. It has 2 main pillarless halls, which accommodates nearly 16,000 guests. That is the biggest of this kind of convention center in India. It includes many halls, banquet halls, and other things also that you can see in this. Okay, that is all about the convention center. This is the mascot of Harvard that was comprising of the Jaipuri Pagdi and healthcare facility, that is apron and stethoscope. Okay. The theme of the conference was cutting edge science in medicine. About the Epicon. Historically, Epicon is one of the biggest scientific conclave for physicians, also biggest in the field of healthcare. Also biggest in the field of healthcare. API was established in 1954 This was the 77th annual conference of the Association of Physicians of India. And the scientific program includes lectures, orations, debates, panel discussions, case-based presentations, workshops, research papers, and poster presentation from the colleague. So in short, it was the biggest scientific conclave for physicians of India and in the field of healthcare. That is what I can say. And this time the registration was somewhere around the 3,000 to 3,500 registration. Usually it is in the range of somewhere 7,000 to 8,000, but this time it was some because of this pandemic, as well as because of the hot temperature, registration was 3,000, somewhere around like that. Now, this conference is comprising of everything, communicable disease, non-communicable disease, and everything. But because of the lack of time, and it is not possible to cover each and every aspect. So at this juncture, I am going to touch only the communicable disease and some part of the communicable disease. I'm not going to touch about the communicable disease. That is what. So in non-communicable disease, I have covered this time the hypertension, diabetes, telemedicine, and hepatology. That is what I will include in this presentation over a period of 30 to 40 minutes. So in hypertension corner, there's a very good lecture by Dr. Misra VN, that is a daily salt intake in cardiovascular disease. Indians on pan-India basis are consuming 9 to 12 grams of salt per day, more than twice of the World Health Organization recommendation. The evidence of relationship between the high salt intake, high blood pressure, and severe mortality is very strong, that you all know. A non-sodium content, that's why they recommended that a non-sodium containing species such as black pepper, hing, cumin, javitri, saunf, ajwa, imli, long, and amchur could easily be used as salt substitutes so as to enhance the flavor of food and at the same time not affect its taste with reduced quantity of salt. So what was the actual conclusion in this lecture was that, and what was the recommendation was that normalization of salt intake from 9 to 12 gram per day to the recommended WHO level of less than 5 gram per day will have major beneficial effects on CV health along major cost savings. Public health advice to limit salt consumption can only be effective in tandem with government. Encourage low levels of salt in content in processed foods by appropriate rules legislation. So they also recommended that there has to be a government legislation or government rules to decrease the salt contents. Food labels should display sodium content and mention daily recommended allowance. That is what the conclusion of this particular lecture. So we have to consume less salt and there has to be some rules and regulation. That is what they had recommended in this lecture. Another lecture was by hypertension in young age by Dr. Bansod BR. Just summarizing that lecture, that artificial stiffness and CVS disease, that is stroke and myocardial infarction, and pulmonary veno-occlusive disease increases with age, that you already know. Aging is a powerful cardiovascular risk factor associated with endothelial dysfunction. In patients with stage 1 hypertension, repeat readings should be taken within 2 to 3 weeks along with lifestyle modification. So what was their importance in this thing is that if you found that there is a stage 1 hypertension, means the blood pressure record between 130 to 139 and 85 to 90, then also you should constantly check that blood pressure very rapidly, not after 3 months or after 6 months, but you have to record it within 2 to 3 weeks only. And that will be very helpful. In patients with stage 2 or 3 hypertension, shorter waiting period will be desirable. As per ESH, ESC and NICE guideline 2019, BP threshold to start treatment is blood pressure of more than 140 by 90 mmHg in young and adults. So they recommended that treatment should be started whenever it crosses more than 140 by 90 mmHg in young and adults. ADS states that all 5 groups of anti-hypertensive drugs can be used, that is AC inhibitors or ARBs, calcium channel blockers, diuretic therapy, or beta blockers may be given as first-line therapy. AC or ARB are preferred first, that in young and adults. Combination was also preferred compared to monotherapy. That was also the very important remark in this particular lecture. Combination of anti-hypertensive drugs therapy in low doses are needed rather than giving a single monotherapy. Monotherapy is very rarely required. That is what important thing we have noticed this time. So rather than giving a monotherapy, low dose combination therapy is now preferred. In young adults, particularly women, renal artery stenosis caused by fibromuscular dysplasia is one of the most common secondary etiologies of hypertension. Even the Takayasu's arthritis is common cause for hypertension in young adults in Asian countries particularly. For this, the digital health solution, counseling services, mobile application, and gadgets which will monitor the diet, physical activity, should be provided to young hypertensive. So they have recommended that in young hypertensive particularly, we should use all these modalities of monitoring to provide a good health and to monitor their blood pressure along with the diet, physical activity. So in young adults, we are constantly focusing on utilization of these newer gadgets or like that. Another important lecture was the 24-hour ambulatory blood pressure recording that by Dr. Maheshwari M. In this particular lecture, they have found that ambulatory monitoring can be regarded as the gold standard for prediction of risk factors related to blood pressures, since prognostic studies have shown that it predicts clinical outcome better than conventional blood pressure measurements. So rather than taking a single reading in an office or a home, they had clearly mentioned that 24-hour ambulatory blood pressure monitoring is a very, very important. And thus, using this particular technique, a good case can be made in all patients in whom hypertension has been newly diagnosed. The monitoring is a program to record blood pressure, usually every 15 to 20 minutes by this particular instrument in daytime hours and every 20 to 30 minutes in nighttime hours. Though some says that it is a very cumbersome, but in my practice, I am using it since last 2 to 3 years, and I found that it is a very, very useful. Hardly anyone has denied to do this whenever I had suggested and indicated in such type of patients. The two detection methods for ABPM are auscultatory and oscillatory, and in this particular thing, we are utilizing oscillatory methods for measurement of these ambulatory blood pressures. More and more use of ambulatory blood pressure monitoring is warranted to precisely evaluate prognostic value of BP related to severe risk. Particularly very important thing what we found in this ABMP is morning rise, nocturnal fall, BP variability, and to quantify both the magnitude and distribution of treatment related blood pressure reduction over 24 hours. So rather than taking a single or a measurement that is in office BP, we have to, whenever possible, we have to use the ABMP, that is ambulatory blood pressure monitoring. It is warranted. It gives a very, very good information, just like what we are doing in CGM, that is continuous glucose monitoring in diabetes segment. So we have to use ABMP, which will give a very good insight into certain aspects and parameters like morning rise, nocturnal fall, and BP variability, which is very important in knowing the or prediction of the hypertension outcome. So this was a very good, wonderful lecture by Dr. Maheshwari. Another important topic in hypertension field was endocrine hypertension by Dr. Kalra. We all know that hormones play a significant role in control of the blood pressure and patients with essential and renal parenchymal hypertension. Hormones play a significant role in hypertension associated with chronic inflammatory states also, obesity, and chronic stress. Among the secondary cause of hypertension, endocrine causes account for second most important cause after renal disease that you already know. So in secondary hypertension, first is the renovascular hypertension, and second most common cause is the hormone or endocrine hypertension, everyone knows. Measurement of fractionated metanephrine and catecholamines in 24-hour urine is the most reliable in diagnosis of the secondary hypertension, particularly endocrine hypertension. And the causes of secondary hypertension included primary hyperaldosteronism, pheochromocytoma, Cushing syndrome are responsible for majority of the endocrine causes of hypertension. Endocrine causes of hypertension may coexist with essential hypertension, that we have to keep in mind. Screening should be considered in patients who are young hypertensives, those with having resistant hypertension, and labile blood pressure and sudden fluctuations of blood pressure. So in such type of patient, we have to try to find out the endocrine hypertension by screening such type of youngs. Most patients can be cured by appropriate surgical and or medical management. Early diagnosis and treatment is very, very important whenever we are dealing with the endocrine hypertension or hypertension problems. So this was a very good lecture, and no doubt. Dr. Muruganathan is a former API president, has also taken a very good lecture that is about the importance of hypertension clinics in India. They have stated that almost 1 in 3 adults, that somewhere around 30% in India is affected by the hypertension in urban and rural. And it has risen by 12 folds and 7 folds respectively in last decades. Just like diabetes, that is diabetology specialty, creating hypertension as subspecialty of medicine and creating more hypertensionologists will aid the sincere efforts and appropriate therapeutic approach. So whatever he has suggested very clearly, that just like diabetologists, now we should have a hypertensionologist, which will have a subspecialties. And to considerably reduce the growing chronic burden of hypertension and its catastrophic consequences in the country. So this is a very important suggestion by Dr. Muruganathan. Treatments needs to be simple, contemporary as per the international standards of care. That was the aim for creating such type of hypertensionologist. Establishing hypertension clinic is cost effective, beneficial for patients and the country too. More hypertensiologists are needed to be guided and developed. Internet should take more interest in starting hypertension clinic. Promote home blood pressure monitoring beyond home, barber shops, library, flats, bus stand, railway stations, airport, etc. So just like in Western countries, what we are seeing that now there has to be some sort of facility to measure the blood pressures in such type of establishments. Every clinic should have ambulatory blood pressure monitoring support. It is time to move from reactive sick care to proactive health care. That is what his remark in this particular lecture. So Dr. Muruganathan has taken a very good, important lecture regarding the importance of hypertension clinic in India. So this is all about the hypertension corner. There were other very good lectures also in the hypertension field, but I'm not going to touch because I have taken saline features of very few selected lectures only. Now, very good important field which was touched during this particular Epicon was telemedicine concept in India. I have taken only one debate or just like one lecture to summarize this. Telemedicine in India. There is an API, that is Association of Physicians of India initiated therapy scientific recommendation in teleconsultation. And that lecture was taken by Dr. Tivaskar M. He has stated that telemedicine gives access to remote areas and to those with certain issues, the power to overcome geographical barriers, the opportunity to reduce healthcare spending also. So in geographical barrier, we have to take this particular telemedicine is a routine part. Also, it reduces the healthcare spending also, that nowadays it is a part of our healthcare system. To make telemedicine a success, there should be an institution of regulatory authority for standard format for the information, a consent form with the option to opt in or to out, mandatory telemedicine courses for all medical students, and refresher courses for medical practitioner, technical staff also. So they stated that the such type of things, telemedicine courses to be initiated right day from medical school only. The authorities should also develop clear guidelines for teleconsulting insurance, guidelines on issues of telemedicine across national borders, standardization of equipment and teleservices with periodic checks and submission to a regulatory authority, equipment liability, maintenance, and safety. So these are the particular parameters or particular things which we have to tackle while when we are initiating this teleconsultation or telemedicines. Telemedicine laws for information storage and access to dedicated staff to manage telemedicine should be formulated and supervised on a regular basis. So before it is to be a part of our healthcare, certain legislator or regulatory things has to be finished. That is what he has clearly recommended. And it was the API initiative. So it is a very important lecture. And now I think everybody has to deal with such type of situations in future. Coming to the diabetes corner. Okay. There are certain important lectures where almost one hall was full of this diabetes and one day fully was there for the diabetes. I have taken only saline pictures of this. First, it was a diabetes care in India, where we are, and where we should be. That was lecture by Dr. Bansi Sabu. From here, you already know that Bansi Sabu is renowned endocrinologist or diabetologist from Ahmedabad, Gujarat. Areas to focus to improve management of diabetes in India. Persons with type 2 diabetes often have delayed diagnosis and inadequate management of glycemia and other risk factors, leading to severe microvascular and macrovascular complications. So early diagnosis and early provisions of basic treatment are crucial goal of health system in India, alongside other important interventions. So early diagnosis and provisions of basic treatment rather than any sophisticated treatment should be the basic aim in India. To achieve the goal of diabetes-free India by 2030, we should aim at having a healthy school kids by promoting health science, sports, and healthy meal in school. Healthy mother and child by providing proper food and nutrition daily in pregnancy. Promoting healthy food, using public transport and regular physical exercise in healthy young individuals. Counseling young girls to eat healthy and physically active. Disease-free adults by maintaining physical activity. Monitoring for all non-communicable diseases once in a year. That is what he has suggested, that there has to be a regular, at least once a year monitoring for all non-communicable disease. That is once in a year, that at the school level or during pregnancy or what like he has suggested to improve the diabetes care in India. Another important thing that you already know, that nowadays diabetes management has changed, or there is a paradigm shift in the diabetes field. That is that you should not only focus the glycemia, but our main important is to prevent the organ damage. That is the target organ protection is nowadays recently is the particularly paradigm shift in the diabetes management. Initially, we were thinking that diabetes management is now only to control the glucose, but nowadays it is not so. Whenever there is a new drug in the diabetes field, also now that consistently insist that there has to be a CVOT outcome trials. So in this particular lecture, that is early end organ protection in diabetes and hypertension, that was by Wagner SK. We already know that 1 in 5 people suffer from diabetes and 1 in 4 people suffer from hypertension in India. So nearly the diabetes population or epidemiology is 20% and hypertension is somewhere around 30% in India. Diabetes and hypertension were co-prevalent in around 1/5 of the patients. So if you take 100 patients of diabetes, nearly 20% are having the hypertension also. And if you take hypertension 100, then nearly 20% are having a diabetes also. The co-occurrence of hypertension in diabetic patients considerably escalates the risk of coronary heart disease, stroke, nephropathy, and retinopathy. So whenever there is a presence of hypertension and diabetes coexistent, then there are four things, that is coronary heart disease, stroke, nephropathy, and retinopathy are almost double compared to whenever there is only single entity presence. Hypertension may present at the time of diagnosis or years after the diagnosis of diabetes. Clinical evidence has shown that in diabetes hypertensives, tight blood pressure control is as important as glycemic control. So this is also very much important when we are dealing with the glycemia control. When diabetes and hypertension coexist, there are exponential detrimental effects on the severe risk due to the occurrence of endothelial dysfunction, micro and macrovascular complications, as well as blood pressure elevations. Early identification is essential, as the patient might not have any symptoms related to elevated blood pressure, and BP should be checked on every clinic visit. So this diabetes and hypertension coexistence with the end organ damage is tremendously, and it has an exponential detrimental effects that everyone knows. Another important thing is the lecture by Prevention of Diabetic Complication, Indian Experience by Dr. Viswanathan. They found that infection is found to be the major cause of amputation in India. Diabetologists displayed a multidisciplinary approach to the treatment and management of food care predicts practices among patients with food complications. The prevalence of neuropathy is higher in newly diagnosed diabetic patients than impaired glucose tolerance patients. According to Global International Diabetic Federation Guidelines 2005, levels of care are standard, minimal, and comprehensive in diabetic food care. Minimal care is the lowest level of care that anyone with the diabetes should receive. That is what is the aim as far as India is concerned, rather than giving a very comprehensive care. Intensive glycemic control, intensive BP control, and overall lipid control causes delaying progression of microvascular complications such as diabetic retinopathy, diabetic kidney disease, diabetic neuropathy, and diabetic food complication. So what he recommended is that in India, very minimal basic care as far as the diabetes is concerned, that is a blood glucose control, blood BP control, and lipid control. If you take the care of these three things, then I think you are definitely able to prevent the progressions of microvascular complications or macrovascular complications, or rather you can delay definitely. Early detection and tight metabolic control is the key to slowing the progression of diabetic microvascular complications. That is what is the clue of this lecture. Another important lecture was management of the diabetes nephropathy. With recent landmark trials, fourth pillar is added to the treatment of patients. That is eGFR more than 25 millimeter of Hg is SGLT2. You already know that nowadays SGLT2, that is sodium glucose transporter 2 molecule, is very, very important. It is coming, and it has definitely given a good hope for the prevention or progression of the cerebrovascular disease as well as the kidney disease progression. It decreases the progression of eGFR by nearly 40 to 50%, and albuminuria decreasing CV mortality and morbidity in all cause death. So utilization of this SGLT2 inhibitor should be there when we are dealing with the diabetes. Standard of care. Treatment of CKD in diabetes consists of AC inhibitors, ARBs, yet these agents remain underutilized in clinical practice. So they recommend that utilization of this AC and ARBs should also be promoted. Along with that, SGLT2 inhibitor is recommended to treat CKD in type 2 diabetes mellitus with eGFR more than 30 millimeter per minute to prevent eGFR decline. So that is what they had recommended, that when there is end-stage kidney disease, heart failure, atherosclerosis, CVD, and death, we have to use this SGLT2 inhibitor along with ACE-ARBs and ARBs. Along with that, GLP-1 receptor agonists are also effective in anti-hyperglycemic agents that reduces the risk of atherosclerotic severity, may reduce albuminuria and eGFR decline also. Awareness of CKD to be increased in patients, family physicians, so that recurrent urine albumin creatine ratio and eGFR measurement is done for early diagnosis, prevention, and treatment of diabetes complication to reduce mortality and morbidity. This is also one of the important things which we have discussed. It was discussed during the conference that the glucagon is a missing piece in diabetes management by Dr. Mittal V. So now you know that diabetes management is not a single faceted. There are multifaceted. There are multi or octogenesis that you already know that there are 8 or 9 pathophysiological aspects to deal with in the management of diabetes. You already know that alpha cells are important in the maintenance of beta cell health and functions. So you should not neglect, while you are preserving the beta cells, you should not neglect the alpha cells. Alpha cells being the more resistant to metabolic status to increase glucagon in diabetes. And the glucagon has 2 distinct roles, reducing food intake and increasing energy expenditure. So we must keep in mind that glucagon has 2 distinct roles, that it reduces food intake and increasing energy expenditure, reducing obesity. So we have to utilize this to reducing the obesity to treat type 2 diabetes mellitus. Classes of drugs being developed to treat glucagon activity are antagonist and agonist that you already know. Antagonist means glucagon receptor facilitator and to treat diabetes, and agonist means glucagon receptors co-agonist to treat obesity. So if you use the glucagon antagonist, it is to treat diabetes, and glucagon agonist to treat the obesity. Glucagon antagonism may reduce the associated hyperglycemia, but may not be beneficial in terms of life expectancy. In glucagon agonism, GLP-1 receptor agonist is used to mitigate any hyperglycemic effects of the glucagon, that is GIP-1 and GLP-1. Glucagon is an important target in the glucagon agonism or antagonism or both. Global epidemic diabetes is depending on which approach is successfully brought to market first, rather than relative merits, demerits of the 2 approaches. So whether we should have a glucagon antagonism or with a glucagon agonism, that only the future will tell. But this is a very important molecule, and that we have to keep in mind that it has 2 distinct roles, reducing blood food intake and increasing energy expenditure. So for the future glycemic diabetes, that is diabetes plus obesity, yes, the glucagon molecule is going to be a very important. Now coming to the 4th aspect of our talk today, that is hepatology. In this field also there were a lot of debates, lot of lectures, and everything was that. And you already know that liver, particularly in India, NAFLD, that is non-alcoholic fatty liver disease, comprises a major chunk. For that, we are having a lot of lectures in this particular conference. A summarizing talk I had included in this particular talk, that is a non-alcoholic steatohepatitis by Singh A. You must know some certain aspect why it is very important that NAS, that is non-alcoholic steatohepatitis, is an advanced form of non-alcoholic fatty liver disease. NAFLD. NAFLD is caused by buildup of fat in the liver. When this buildup causes inflammation and damage, it is known as non-alcoholic steatohepatitis. If there is only accumulation of the fat, it is non-alcoholic fatty liver disease. But whenever it is associated with inflammation and there is a damage, it is known as non-alcoholic steatohepatitis, which can lead to scarring of the liver. The first stage is referred to as simple fatty liver. That is already you know, that is a steatosis. Second stage is that is non-alcoholic steatohepatitis, that is NAS. So first stage is NAFLD, that is fatty liver. Second stage is steatohepatitis, that is NAS. And the third stage of NAFLD is fibrosis. And the 4th stage of NAFLD is cirrhosis. And some cases may develop hepatocellular carcinoma that we also have to keep in mind. So there is a spectrum of NAFLD. That first stage is steatohepatitis, then NAS, then fibrosis, and then cirrhosis. And remember this particular epidemiology as far as the incidence of India is concerned. The estimated numbers are somewhere around 30%, that's 16 to 32% of the general population in India. Nearly that is 120 million has non-alcoholic fatty liver disease, and among them nearly 31% are diagnosed with NICE. So 30% of the populations are having a fatty liver, and out of that 30% are having a NAS. So it is a very, very important. 63 million Indians are having a type 2 diabetes mellitus that you already know, and among them nearly 70% are having a NAFLD, that is a 44 million, and 1/3 of the NAFLD population estimated to have a NAS, that is 13 million. And particularly this NAFLD is increasing in urban populations, more in urban areas compared to rural areas due to the presence of multiple risk factors. And why we Indians are having a more such type of NAFLD or NASH, that is NASH, because Indians are more prone to Western world compared to other races due to the presence of higher insulin resistance and higher fat levels, that is triglycerides in blood. We have genetically more visceral obesity and less subcutaneous fat, and these are the most important causes, and that's why we are suffering from this NAFLD. So we have to deal. There were a lot of discussion regarding the diagnosis, and there is a batteries of investigation, particularly importance of fibroscans, and everything was discussed very nicely in this particular EPICON. And there were also now clear-cut treatment guidelines, or rather some facts has already been established regarding the treatment of this NAFLD. So there are 4 segments when we are dealing with such NAS treatment. That is a hepatic fat accumulation, that is with the help of peroxisome proliferator activator receptor agonist, that is pioglitazone, elafiprinator, and sarglitazole, that we already know. Targeting bile acid, farnesol X receptor with the help of obeticholic acid. Inhibiting de novo lipogenesis with the help of aramcol and incretins also. Another important target is the targeting oxidative stress, inflammation, and injury following metabolic stress with the help of antioxidants. Particularly the role of vitamin E was very much, and particularly pentoxifylline were very much discussed in this particular aspect of hepatology. And there were also immune modulators like amecloxanoxane, which are at present not available in India. So another important targeting segment in this particular NAFLD was targeting gut with the help of anti-obesity agents such as orlistat. Gut microbiota modulators like immunone fecal transplant also were discussed. And fourth target thing was in this particular NAFLD was anti-fibrotic agents, that is simtuzumab and GRMD02. See, these all factors were very well discussed in this particular EPICON hepatology segments. So as far as the scientific aspect is concerned, I think I restrict myself at present with this 4, that is hypertension, diabetes, telemedicine, and hepatology. So in Jaipur, as you already know, there were a tourist place. Also, it is a World Heritage city. It is also known as the Pink City. Also, you all know, we have taken the visit of 3 particular things. That is Amer Fort. It is located in the Amer, which is around 11 kilometers from Jaipur. It was constructed by Raja Mansingh in the 1552. It was later expanded by the Raja Jai Singh II. The raised stone and marble stone construction reflect a blend of Hindu-Muslim architecture. That was the first capital before the Jaipur. It was located in the Amir. Another important marvel of peace was in Jaipur was the Jantar Mantar. That is Jantra and Mantras combination. It is only 2 places this Jantar Mantar is there in India. It is not just like any other average observatory. It is ranks amongst the largest observatories of the world, built during the period of Maharaja Jai Singh II. The astronomical observatory has the largest sundial of the world. That is the most important thing you already know. And that was somewhere in the 17th century, quite way back. We are having a very rich knowledge of such astronomy in India. And this is the third most important thing, that is the Hawa Mahal of the Jaipur, that you already know. It is not to miss tourist places in the Jaipur. The Mahal was constructed by Maharaja Savai Pratap Singh in 1799. True to the name, it is on as the place of the winds. And we must know that Hawa Mahal has 953 windows to provide ventilation. That is the most important attraction when we are visited the Jaipur. I think that is all at this juncture. We had already crossed 45 minutes. So anything you want to ask me in this particular, I am ready to answer.
Thank you, Dr. Kiran Bhai. As usual, you've been very lucid and very crisp in giving very important messages that you learned in Epicon. You can stop the screen sharing, so that we can see faces.
Okay.
There is one question in the chat box, and that is regarding role of exercise and yoga in diabetes.
It was very, very clearly, and it is already established that there is a definite role of yoga and exercise, undoubtedly. Before starting the pharmacological therapy, yes, we have to offer this lifestyle modification, that is yoga and exercise. It definitely helps to improve the glycemic control and other metabolic control also up to the 5% level. Yes, that is a very well established fact. And yes, there is no controversy about it. Yes, and they recommended here also, there were discussion about this, that exercise, that per day 30 to 45 minutes per day exercise, and in a week at least 5 days a week. If you do such type of exercise or yoga, yes, you will definitely expected benefit in glycemic and other metabolic control, particularly metabolic parameters like cholesterol control also. So there is no doubt about the use of these modalities of treatment, non-pharmacological.
There is another question from Dr. Trivedi, and that is regarding how can the progression from first to fourth stage be prevented in NAFLD? So
yes, that is the most important. At present, there are no clear-cut guidance. Just the only thing is that education. Particularly, what we have told is that we Indians are suffering more and more, that is particularly insulin resistance, and that is triglyceride content particularly high in our Indian diet. So if you give certain good education, and if you try to find out the insulin resistance early, if you suspect somewhere that is like say NAFLD, with the help of just borderline raise of the liver enzymes, that is SCPT or SGLT, by chance, suppose you find, if the patient doesn't having anything, and on routine investigation, if you find that there is slightly elevation of this SGPT or SCOT, and at that time, the suspect take the thorough history, find out whatever the possible causes, why it is slightly raised. Just do not neglect why it is only raised simply, and it will come. At that time, if you will target, if you will try to find out the real cause of this elevated SGPT or SGOT, yes, I think that is a very important. Even certain newer modalities of investigations like routine use of sonography, and particularly advanced sonography, that is fibroscan, which is also very important. Now it is very easily available in Baroda too. So it will also help in early diagnosis of this NAFLD. That will also help in prevention or regarding the regression of this NAFLD. Particularly, if we must know that at least it takes at least 10 to 20 years from stage 1 to stage 2. So by chance during this particular period, if you come across such things, yes, you have to thoroughly investigation and try to find out the real cause. and treat accordingly with the help of simply, that is what I help. You can use it a simple antioxidant also that will help in regression of this to certain extent. Avoid the bad habits, that is using this more and more triglycerides in our Indian diet. I think that is the only thing what we can do.
How much is the relation with obesity? I mean, how many of percentage of obese people will get NF?
Sir, exactly, it has not been found out, but in diabetes and obesity, they had found that nearly 70% of the patients are having this NAFLD. So that is a very good reason that if you are having a diabetes and obesity, yes, you are having a 70% chances that there is a NAFLD, that is non-alcoholic fatty liver.
And Dr. Chetan is asking about timing of anti-hypertensive medication.
Timing means there were a lot of discussion, like say somewhere the calcium channel blockers are when we are giving it at the end of the day, yes, it is very helpful because it helps in night non-dipper also. Whereas other routine drugs can also be given in the daytime also. So depends actually upon the ABMP monitoring. If you find that the blood pressure is more high at the night time, yes, you give the medication at the evening hours. And if you find that the blood pressure is more high during the daytime, you give the blood pressure medication during the daytime. So that is what is the clear cut. For that, you have to use the ABM. You find out where exactly the blood pressure is more elevated. It differs from different to different people.
So this ambulatory BP monitoring, I mean, how easy or difficult it is? Please tell us, because we pediatricians do not know about.
Satish bhai, I am using it this type of modality of BP monitoring since last nearly, I'd say 5 to 6 years, from 2016 onwards. Practically, once you apply it, initially, yes, or 1 or 2 reading may be high or there may be a difficulty. But once you explain it thoroughly, I have found out it doesn't even disturb the patient's sleep also during night. You can lie down supine, left, right position also. There is no harm actually. Patient doesn't tell, and none of the patient has complained that because of this instrument, my sleep is disturbed or my routine activity is disturbed. You can allow all the routine activities during the daytime also, except bathing, because that contains the instrument. And sometimes if you very well educated patient, yes, there is a possibility that you may put this instrument like mobile away from the patient also, because there is a long tube. So even you can lie down on the supine also. So practically it doesn't interfere with your day-to-day activity. And usually if you explain it thoroughly or educate the patient thoroughly before giving this particular instrument, yes, I have given nearly 99% results.
Dr. Chetan is also asking about any clues to suspect secondary hypertension.
Particularly, yes, young hypertensive, that is. Second thing, whenever there is a fluctuating hypertension, whenever there is a labile hypertension, and whenever there is a resistant hypertension. These are very important 4 clues. If such things are present, yes, you suspect that there is a possibility of that type of hypertension. So this may give certain clues. And while investigating, they clearly find such type of hypertension. The most important thing is the fractionated metamethrin and catecholamine investigation is what they have suggested.
So questions in the chat box are over now. It's open for others to make their comments or ask questions.
I am very glad. Actually, it's my pleasure to see all respected seniors like us also after a long time.
So Kiran bhai, what we'll do is we'll have your part 2 or even part 3. There are a lot of other things left out.
Yes. Communicable disease, yes, everything has been left out. Ischemic heart disease, failure. But because it is beyond, because everything I have to tell something very important thing. Right, but it doesn't take, it takes a long time.
We'll have another session with you. I think that is what we do. Last year, when Dr. Chetan attended a similar conference, we had 2 sessions from him. So we'll have another session. So any questions, comments from anybody? Jagdish bhai
Any
wants to-
role of fasting in controlling fatty liver disease?
Fasting in controlling fatty liver disease? No, no idea, sir. Huh? I have not come across such thing. I don't know anything.
Hello.
Hello. Yes.
Intermittent
yes.
fasting. You mean
Good morning, sir.
Calorie restriction and intermittent fasting.
intermittent fasting.
Intermittent fasting and calorie restriction.
Yes,
Both are
indirectly.
advocated for reducing insulin resistance.
Yes, yes. Indirectly by controlling that insulin resistance, it is definitely helpful in, yes, definitely. So intermittent fasting, chrononutrition, that is timing of nutrition or food intake, that has been also clearly discussed. I have one slide for that also, but because of lack of time, I have not discussed. That is very important. Agree, fully agree with you.
Another problem faced is sodium depletion in old age. Some of the very elderly people find that their sodium level gets low.
Yes, yes.
Now with salt restriction and
yes, particularly in elderly
balance it.
population. Yes, particularly in elderly population, we have to closely monitor while we are using such type of SC inhibitors or ARBs or SGLT2 inhibitors, volume depleters, or diuretic, particularly in our Indian countries, particularly tropical countries like India. So we have to be very careful, and we have to closely monitor this sodium content. Yes, very clearly.
Hello.
Yes.
Hello. Good morning.
We
Yes.
are able to hear you. Please ask question.
Excellent lecture, and particularly very true for pediatricians who are of the adult practice, like diabetes and hypertension. I want to ask one question that we see too many obese children in our practice.
Yes.
So how long should we start investigating those children from point of view of non-alcoholic fatty liver disease in long run, maybe on yearly basis? Because we see, say for example, 80 kg child at 12 years of age. Too many children we often come across. So what is your advice, sir, regarding that?
Particularly, they had found out there's non-invasive technique like NIT, that is non-invasive technique, particularly EPRI score. If you are aware of that EPRI score, that comprises liver enzymes and simple utilization of the sonography. So while you are dealing or doing routine investigations of such type of obese children, these two things we have to closely monitor. So whenever you found that some sort of altered echogenicity, particularly, you start investigating further in this particular thing.
So suppose if I have got the sonography report stage 1 fatty liver disease to a 15-year-old child like that, then what would be my further advice?
Yes, then you have to investigate thoroughly. There is no question. You should not leave it. Yes, after 3 or 4 months we will wait and watch and we will do. Or at least you educate the people that there is something wrong with your liver also, and don't just let them go. That is what my clear-cut advice.
Right.
Oh, Sunil, when we investigate any child for obesity, along with lipid profile and all that, we do investigate at least SGPT we ask for. And if it is there, then we do the sonography. And I think in early stage, we don't intervene except lifestyle modification, and we keep following. That is very important.
That is, yes.
Follow-up is very important.
Yes.
Excellent. Thank you.
Yes.
So if there are no questions, I think we close the session here. And thank you once again, Dr. Kiran Bhai. And we'll have another session on the same conference synopsis, maybe next week or sometime later. So thank you all for joining. We meet again next Saturday. Thank you all.
Okay, thank
Close
you.
the meeting here.
All,
thank you.
Nice to see you all seniors, particularly. I'm very delighted to see all, particularly sir.
Thank you. Thank you.
Thank you.